I'm John DeVaro. I'm a private practice peds op in Savannah, Georgia. I've been there since '97. Ron asked me to run this panel from the standpoint of a clinician. And I'm an assistant clinical professor at Mercer in Savannah, and I also work with the Augusta students. I'm a consultant, but I'm not an investor. And I've been using the device since January 2023, since the rollout. And what I can certainly say is there's no question in my mind that it works. My greatest barriers to enlisting new kids now, initially, with the initial rollout, I could offer this device for free. And if you compare a free device to patching, I can assure you that the enrollment was very heavy. Once we moved out of that phase, with an initial price point of over $300, there was great resistance from my patients. So I can't stress how much the news from Ron today of reducing the price and also the insurances starting to gather on is great news to me. If there is another barrier, it's not one to me, because as the doc, you just hand off your enrollment information. At the moment, it's like he said, it's either on the little portal or a fax, but I'm very anxious to get straight out of the EHR. I'm on ModMed, and that will make things even better. So they asked me before I bother the people next to me to just give a quick anecdote. I don't have Dr. Wignansky-Javsky's great slides, but something that just came in over Valentine's Day. Just the newest success was a 10-year-old, and mind you, off-label, because remember, officially 4 to 9, but a 10-year-old had come into me as a second opinion. They had left one optometrist because they had recommended patching and atropine. They'd gone to another optometrist in town who was recommending vision therapy, so they came to me. And they were 20/20, 20/40, no refractive error, plus 50, plus 75. And they had a micro ET of 4 diopters at near and distance, no stereo. And this was April of last year, so my usual spiel now is I will offer atropine, I'll offer patch, and I'll offer dioptic therapy. And mind you, they were not interested in doing either of the former two things, so they went straight to CureSight, and that was in April. They came back in July, 2040 had become 2025. They came back in September, 2025 had become 2025 plus 1, and it was September, now school had started. I was pretty sure in my heart if they came back another 2 to 3 months, they would be 2020, but it's school, it's soccer, they want to stop the device, they sent it back. So it was one of the first patients I said, well, please, will you consider patching an hour a day? Now, this is the same family that had refused before, but now this is a family that thinks you know what you're doing. They've seen the child improve, and they said, sure. So that was in September. Savannah had a little snow event in January, so they didn't keep their follow-up, and they came back on Valentine's Day, and the kid's 20/20 both eyes. His ET is down to 1, and he's got 400 arc seconds of stereo. So I think that's a success in my book. So with that in mind, I'm going to turn to Dr. Silbert and ask, why did you start CureSight?
Patching sucks, basically. And, you know, we typically don't have patients starting, and I'm not a paid consultant for them. I'm just here because I like the device. We typically start patients on patching or atropine, and they come back and they tell you that they're compliant, but they're not improving. And I don't really believe they're compliant. So, you know, having an option other than patching or atropine, especially for a patient who's theoretically been patching, but probably isn't, it's a great option. And so, you know, talking about an anecdote, I had a patient who was about 7 and recently had come back and had theoretically been patching, was in glasses. There was no deviation, and they just hadn't made any improvement. And so, you know, I prescribe these things. I submit it to my staff who figures it out. And basically, as you're seeing them back, you can get in the portal. And what I don't get in the portal personally, what happens is someone in my office goes in, downloads the data, so I can see at the visit or prior to the visit, you know, how compliant they've been. And this kid actually improved to 20/20, you know, and I was actually surprised by that. I think that the patients who don't have a deviation improve better than those who do, but I think small deviations seem to be okay.
Now, Dr. Wignansky-Jaffe, you pointed out you had a posterior lenticular cataract, and you were able to make them patch and use CureSight simultaneously with no resistance?
I was able because I didn't want to give them the CureSight because I had no data on that, and I didn't feel it was responsible on my part to. I usually give treatment based on clinical data, which is verified on studies. So just because they told me she's not going to patch anymore, we did this combination therapy, and for this child, it worked out well.
If this child came in next time, would you still add the patch?
Probably yes.
Okay, very good. Now, implementation-wise, as I mentioned, it's not a big deal with the portal or with the fax. Is it the same thing in Israel?
In Israel, it's different because we don't have the EHR and the management you have here. But we're a small country and much more integrated, so we do it differently, but we do collect the data on the patients, and that's a big advantage. And we also follow a lot of our study patients for many years, and that's also an advantage to see how they come through, what happens with them, and how visual acuity is several years after. So that's been a great advantage in a place like we live, which is a small country, and we see our patients over and over again.
Now, the monitoring center, as Dan mentioned, compliance has always been an issue for us. I always tell my residents, I don't know, some of us who are old enough to remember when we patched 8, 10, 12 hours a day, then I would know if the child was patching if they had subderm around the eye. But with 1 or 2 hours a day, you have no idea if they've been patching. Atropine, if the child happens to come in dilated, I'm still not sure if that was the first drop last night. But we've got the monitoring center now, and I have a couple jokes that I use with my kids that some of you heard before, but on the one hand, I'll tell the kids when we're signing up, we're going to be watching you, because we can, but then also in September when they come back and they haven't been using the CureSight, and I know because my optometrist has filled out a report on Emma that says whether they've been compliant or not. But you can pull up the, I've got this iPad, you can pull up the monitoring center if I've got a bad actor, and I say, I've changed a little bit now, I say, I not only know what you did last summer, I know what you did yesterday. So, Dr. Silber, do you do that kind of stuff?
I don't pull up stuff in real time. I basically have my staff. I'm very dependent on the kindness of others. I can't function without significant staff. They put the stuff into the EHR, and I look at it with the patient, so it's scanned in, and I can say, oh, you've had good compliance, and that's how I do it. So they do know that we're watching, but not quite the same as you.
So I found out news as I was invited to do this panel about the older kids and the strabismic amblyopia studies. When do we think we'll see data with that?
So I'm not. I see Eileen Birch in the crowd, so I don't know. It's totally her own initiative, so we have actually no timeline on that. So okay, strabismic, the development will take some time.
Sure.
So we think it would probably, the R&D would be finished by the end of the year, but then we have to repeat the pivotal study. So it's still a few years ahead until coming to market.
And Drew, I understand that we may be working on making this device accessible straight from our orthoptic clinic.
Sure. Yeah. So if orthoptist has an active NPI, then they can refer it directly. If they do not have an active NPI, then they can refer on behalf of an MD or an OD.
And keep in mind this 0706T code that your monitoring person can use, because if you're seeing the child every 2 to 3 months, but as they're monitoring for you, they do submit that CPT code. In my experience, so far, the insurances have covered it at most 10 to 20%. But I feel with dichoptic therapy in general, the more of us that are using it, the more of us that are sending this stuff insurance companies' way, the more we're going to get acceptance of this. And I think it's, at this point, with the ability to offer multiple options, a vital part of my practice.
Can I just say something? You know, there's talk, and many people say, we don't need this because patching works. And patching does work, but patching doesn't work if kids aren't patching. And maybe it doesn't work all the time, even if kids are patching. I think what's interesting about this device, just the eye tracking, and I suspect it's the eye tracking that makes the difference. The results have been very, very good. I mean, these studies have been very robust, and there are more studies. And, you know, I'm very interested in seeing what Eileen Birch's group does and what they find. So that's one thing. And then the other thing is this concept that this is so expensive. You know, I see thyroid patients, and I've put 15 patients probably over the past few years on teprotumumab. And the cost for that is somewhere between $350,000 and $600,000. And so you look at this and you sort of say, we don't have treatments like that in pediatric ophthalmology. This is a relatively, even though it's more expensive than patching, it's a relatively inexpensive treatment. And so, yeah, maybe I'm not going to put every kid who walks in the door on this, I'm going to try patching first, and others might do differently. But when I'm having trouble with patching, I don't want to go for 9 months making no progress. And that's what I see all the time. Patients are lost to follow-up, they show back up, and they're still amblyopic. So I have a very low tolerance for insurance companies saying, no, we don't think this should be covered. No, there's not adequate evidence. There is adequate evidence. There's very, very good evidence. And so that's just how I feel about this. I'm not saying it's right for everybody, but I do think it should be an option. I do think insurance companies should pay for it, and I don't think it's expensive.